We're very happy to see all of you here tonight. My name is Julie Kilpatrick, and I'm a Valley resident, a nurse, and a member of the Higher Ground for Healthcare Committee of the St. Croix Valley Women's Alliance. The St. Croix Valley Women's Alliance was formed late 2016 with a mission to protect and champion the human rights and well-being of our diverse society. The St. Croix Valley Women's Alliance has over 700 members who are organized around issue-based teams focusing on healthcare, political engagement, human rights, education, and environmental issues. New members are always welcome. We are honored to partner and co-sponsor this first healthcare forum with the League of Women Voters, White Bear Lake.
Hello, I'm Liz Lauder. I'm the president of the White Bear Lake Area League of Women Voters, and I'm also the secretary for the League State Board of Directors. And I'm happy to be here tonight to co-sponsor this event with Julie's group. And I've been a member of the League for about 6 years, and one of my favorite things about the League is the work that we do to educate people on important issues of the day. And we do not support or oppose political candidates or parties. What we do is provide a safe space for them to come together and to discuss their views on solving the intractable problems of the day. The views that are expressed are the panelists' own and do not necessarily represent the views of the League of Women Voters. We're in our 98th year, and we grew out of the women's suffrage movement. It became necessary almost overnight to educate a large demographic of our country on the issues of the day and on how to advocate for those positions. And so that's how the League came about. Our doors are open to everyone. It doesn't matter your age, your gender, or your citizenship. We welcome everyone to come and find out more about us. And we hope that you learn something here tonight that will help you form your own viewpoints on this topic. And so with that, I will turn the mic over to our moderator tonight, who is Miriam Simmons. Miriam is a 20-year League member. She is a registered parliamentarian. She said that the process for becoming a parliamentarian was torturous. And we're glad that she did that so that we don't have to. And she comes from Texas, and we all know that you don't mess with Texas. So with that, I'll give the mic over to Miriam.
Thank you all very much. First, I think I have to say that we have just this instant found out that one of our panelists cannot be here. He's missed his airplane or missed his flight, or we're not quite clear, but he's not here. So we will have to soldier on without Mr. Slavitt, and I'm certain that we can get an awful lot of answers to an awful lot of questions with our four very good remaining panelists. So first, let's acknowledge any elected officials in the room. We were hoping lots of them would be joining us this evening. I know we have at least a school board member. If you would stand and be recognized if you are an elected official. Or maybe not. Okay. Thank you very much.
Funny.
All right, second, I'll be introducing the panelists, but before that, I would just like to review the ground rules for the forum. Okay, each panelist will have 4 minutes for opening remarks, and that's to put the evening in some context for us. Then the panelists will take questions. Each panelist will have up to 2 minutes to answer a question, and each will have 2 minutes for closing remarks. So if it develops that there needs to be what we could term a rebuttal, there will be a minute for a rebuttal. So if something seems to need more explanation from maybe a different angle. I don't want to imply we're arguing. That's the thing. Okay, the timekeepers are right in front, and that's important for our speakers to see. So we want to, as much as possible, keep to time so everybody can have enough time to speak. Each of you should have a 3x5 card. You got one when you came in. It was in your program. If you don't have one or dropped one, or you need to write multiple questions, that's totally fine. We have some helpers running around with other cards. If you hold your hand up, you can get another 3x5 card. As to the questions, there's a panel of 3 over here who will look at the questions and they'll get them to me. The reason for this is people ask the same question, basically, similar questions, so they'll eliminate some duplicates, maybe combine some questions, and they'll rephrase some questions. If we can't read your card, we can't ask your question, so please make it legible. And we probably won't cover everything, but hopefully if there's a few moments after the forum ends, you can try to get a question answer from one of the panelists. So there's a lot of information to cover. We'd like to, as much as possible, hold applause and cheers and anything else till the end. And then you can applaud all you want, okay? All right, in alphabetical order, our panelists are Senator Jim Abler, who represents Minnesota District 35. This is Anoka, Ramsey, Coon Rapids area. Senator Abler is also a chiropractor. In the Senate, he's currently chair of Human Services Reform, Finance and Policy Committee, and he serves on the Health and Human Services Finance and Policy Committee, among other committees. Matthew Eastwood is the Chief Executive Officer of Canvas Health. Canvas Health is a nonprofit human services center that helps people recover from mental illness and substance abuse, among other things. He formerly has held positions with Health Partners Medical Group and with Blue Cross Blue Shield. Senator John Marty represents Minnesota District 66. This is Roseville, Falcon Heights, and the northern St. Paul area. He's had a long-time interest in campaign finance reform. I have to mention that because it's a league thing. And universal health care. He serves on the Health and Human Services Finance and Policy Committee, among other committees. Kathleen Picard owns a health policy consulting firm in the area of physical therapy practices. She's an associate faculty member at the University of Minnesota in the Doctor of Physical Therapy program, and she's an appointed representative for the American Physical Therapy Association in policy advisory roles. It's too bad Mr. Slavitt, who could not join us because he was the acting administrator for the Centers of Medicare and Medicaid Services for 2 years, but we'll hope we can take up some of that slack. All right, so now opening remarks are for 4 minutes, and we begin with Mr. Abler. We'll just go down.
Well, thanks for having me, and thanks for all being here, and thanks to the League and the St. Croix Valley Women's Alliance for doing this. And I think it's timely and productive, and it's clear that there's probably the Vikings ratings are down tonight because of you all being here. So I commend you for your making the wiser choice. It's too bad that Mr. Slavitt couldn't be here. I like him a lot, and I think he would have added something. But I think you have a good range of thoughts up here. And sadly, if he would have been here, we could have actually solved it tonight, but I guess we won't have to. We'll have to go on and have another meeting sometime. You know, you're here because you care about health care, and I would suggest if we were going to sit down and define health care, if there's 150 people here or whatever, we'd probably have 160 opinions on what that is. But I will just remind you, whatever we decide tonight, that health care is not about having a card. And so it seems as though in the debate, if I can just get you a card that says the name of some plan on it, that we have solved the problem. And I will assert to you in the beginning of the discussions, nothing could be further from the truth. Particularly if that card has a $12,000 deductible on it, or if that card doesn't include the doctor of your choice, or the kind of doctor you might need, or the kind of doctor you don't even know that might help you. And so, as a 38-year chiropractor, my idea about healthcare is that it should actually make people healthy, and that you all seeking this healthcare answer what you're really after is, can I be as healthy as my genes allow me to be and maximize the enjoyment of our life on earth and service that I choose to do, and being with my family and friends and accomplishing the good that I'm destined to do. And so that's a different discussion, I think, than what it's turned into. And so I'm looking forward to the discussion tonight, and I could ramble on for 4 minutes, but I'm going to give you, since I have 4 minutes, I need to give you a little bit of content. And so just in the big picture, I'll outline what would be my plan if I were going to redesign things and remind people of it. The first thing is I would remind you that there's some personal responsibility, and that if I'm going to give you health care, how much health care could you consume if you don't do anything right? Way more than if you did something right. Many people have issues where they were injured or have some genetic issue, or they were born with something, or something happened to them. Well, you can't control that, but there are many things you can control. And that has to be part of the equation in the beginning. We've evolved into the second thing is that, what if doctors were allowed to doctor? And the people would actually have the right to just sit down with their doctor, and their team of different clinicians decide what might be the best course for me, instead of worrying about to hurry through the visit, or there's some kind of limit on what you can do, or even what kind of doctor you can see, or what kind of clinician you can see. What if that were so? And in my world, I don't know if you realize, a lot of people come to me last. They spend $8,000 on some array of care, MRIs, and even maybe a surgery or so, or just a bunch of things they do. It doesn't work. They come and see me, and often for $300 they're better. You know what Blue Cross tells me? $300, really. And finally, what if we return to a service ethic in the systems, on the providers, the health plans? At a meeting like this, if we were in the health plans and all they'd be here, they'd be saying, how am I still going to make my money? And so those are the elements I will be pursuing, and I'm really excited about the discussion tonight. So thank you.
First of all, thank you for having me here tonight. One thing, I am a little bit different animal than my co-panelists here, I think. They're certainly policy people and work on a broader scale, larger scale than I do. I'm just a guy who runs some mental health clinics, so I come from it from that perspective. It's a little more narrowly defined. I do want to point out one thing. One of the earlier flyers for this program said that I was a former and current health plan or health insurance executive. If you were hoping to come and have a shot at your health plan, health insurance carrier, I'm not that guy. I worked for a health insurance company for a brief period of time, but I did not drive that. I was not an executive. So just to be clear about that. I do want to talk a little bit about the organization that I represent. And I do that not as a sales pitch, actually, but so that you have an understanding of where I come from and what I care about and what I think is important, hopefully, to this discussion. And most of you are probably not familiar with the organization I represent. Canvas Health, which is the organization I run, was formerly known as HSI here in Washington County. We've been around 48 years. We have been the community mental health center, the safety net provider in Washington County for that entire time. We employ about 340 people. We have about an $18 million budget. We have 35 programs, and we see over 8,000 people a year in face-to-face visits. And in addition to that, we run the only certified telephonic suicide prevention call center in the state, Crisis Connection, and the Text for Life program, which we operate on behalf of the state of Minnesota. Why that's important is that I think it goes to a little bit about where we're at today, at least with mental health care in our society. Community mental health really got its start back in 1963 when President John F. Kennedy signed a bill that really started the community mental health movement. As we all know, he was assassinated, and actually was assassinated about a month after he signed this bill, which of course, along with stopping a lot of other initiatives, really took the steam out of the community mental health movement. That being said, the original goal of the community mental health movement was to create a series of treatment centers across the country, 1,500 of them, in fact. And the real focus of those community mental health centers were to be that safety net for the community. It was to work with the people who were then, at that point in time, coming out of state hospitals, coming out of asylums. We had some new medications that were on the market that were helping people better manage their symptoms. We had new treatments that seemed to be effective, and we were going to build all of these centers to help people. The reality is we never built half of them. And from the point that President Kennedy signed that bill, it's been attacked repeatedly, pulled apart in ways. People have tried to defund it, diminish it, make it less than it was ever intended to be. And in fact, as I said, it never got built. You'll often hear people talk about the mental health care system being broken. And I would contend to you that it's not broken. We have incredible people doing great work every day. The problem is we never built the system. We never built it. For whatever reason, we never had the courage, the energy, or the gall to say that we were going to get this done. And so it didn't happen. And this is despite the fact, I'll throw this in pretty quickly here because I'm getting signal, that we have 40 to 50 years of good clinical research that shows that it's effective and it works. It works as well as medication. This is in addition to our own Office of Budget and Management at the state, which has done statistical analysis and financial analysis using algorithms out of Johns Hopkins University, which shows a return on investment from 2 to 1 to 66 to 1, which means for every dollar spent, society gets $2 back. Not only do you get good outcomes, but there's a return on that investment. Thank you.
Thank you. I also want to thank the League and St. Croix Valley Women's Alliance for hosting this, and very much appreciate the mix of providers and policy folks to talk about healthcare. I'm going to start by saying that I think we've got a great healthcare system, great healthcare available in this country, some of the best there is. But like Matthew just said, we don't have a good system for accessing. We've got some of the best doctors, hospitals, dentists, clinics, nurses, chiropractors. We got some of the best of everything in the world, and the worst way of accessing it. We don't have a system for it. That's why we have shortages of psychiatrists, we have shortages of certain types of medical providers, and we have a lot of people who can't get it. We also spend twice what any other countries in the world spend on healthcare per person. Twice. There are about 6 or 8 exceptions to that, but those 6 or 8 exceptions are way below where we are. But everybody else is half what we spend or less. And our outcomes are not better. Infant mortality, life expectancy, normal measures like that, we do worse than them. And when we talk about fixing the system, we're always trying to save money because it's too expensive. But to me, what Matthew just said a minute ago, we don't have a system in mental health. We don't have a good healthcare system either. And so I'd argue that we should be starting not from scratch, but starting with what we have and saying, how do we put together a system to make sure it works? One that covers everybody. Again, we're the only industrialized country on the planet that doesn't cover everyone. And bring down the costs and make sure that people have the choice, not insurance companies or government or somebody else. That people have the choice of who their doctors and their providers are. And people and their providers are the ones who make medical decisions, not an employer or insurance company or government. And so I proposed a Minnesota health plan that I'm arguing is what we should be trying to do. And my pitch is that even if we cover everybody, and we cover them for all their medical needs, including things like dental and mental health, we can do that for less than we're spending now. Why? That's counterintuitive. We're going to cover more people for more things. The way I try and explain it is to suggest that let's compare the way we fund our schools with the way we fund our hospitals. If we were to do that, our schools would have a lot of new things happening to them. Every teacher would spend half hour more every day calculating how much time he or she spent with each student, big variation. Some of them have more supplies, you have to factor all that in, and then he or she would send it down to the school's billing office. Not about Stillwater, but in Roseville, they don't have billing offices. And the school's billing office folded in all the overhead, the capital expenses, janitorial expenses, utilities, and they'd send out a monthly bill to the parents' school insurance plans. And that plan would be fairly expensive, so employers would be wise to step in, start offering school insurance plans. And not everybody can afford the plans. Some people can't afford the co-payments, so you're going to have, schools are going to need a collections agency as well. And some students who can't get plans, the government would step in then and provide subsidies to those who have to buy school insurance on the individual market. We'd have a good system for all that. Would that improve education? No, it would take teacher time, administrator time away from educating and into billing. Frankly, parents who should be spending more time helping their kids be taking their time away to figure out the billing. Sometimes you'd switch jobs and you'd get a different plan. You'd find out your school or some of the teachers in it are out of network. You wouldn't save money. It cost you a fortune more. And it doesn't make sense to do it that way. I'm not saying we should fund health care the way we fund schools, but we need a plan that covers everybody for all their medical needs. And realistically, we can do that in a way that saves money. And that's what I'd like to make the premise we ought to be doing instead of tinkering as we've been doing at both the state and federal level for 30 years. Thank you.
I'll join the others in thanking the League of Women Voters and the Women's Alliance for organizing this event and for honoring me to be part of this panel and to answer your questions and have a dialogue around how do we change the way healthcare is delivered. The United States struggles with the same issues every other country struggles with regards to healthcare. They have to answer 3 different questions. Who should get health care, how much, what kind of services, and then who pays for it. But in the United States, we get stuck on the who pays for it. So all we talk about is insurance reform and who's going to pay for what and who's responsible for that. And so tonight I'm really happy that we have this opportunity to change the discussion a bit and open it up to talk about how do we change the way we actually deliver care so that we get value for the dollars we spend. When I think about healthcare reform, I have 2 basic tenets. For me, I think of health as an asset. I try to stay away from the right, is it a right or isn't it a right? I think it's an asset. It's an asset, obviously, to the individual. It's an asset to communities. It's an asset to employers. Health is an asset to society at large. So given that, it's something we ought to all be behind because it's an asset. It shouldn't be political at all. My second tenet is that healthcare is different and much larger than medical care. But again, we focus on medical care and all that goes with that. And in our country, our current model of medical care is somewhat analogous to hockey goalie. We can deflect death. We can deflect the consequences of illness and conditions that people have. And that has spawned an entire industry around pharmaceuticals, medical procedures and devices, and invasive procedures. And so that's where the money flows. And instead of that, I'm offering the suggestion that perhaps we should be looking both at the health of our population, how do we become more healthy, and also look at where medicine meets where medicine meets health. I see it in our current model of medical care. We're very physician-centric and very hospital-centric. I'll explain that. It seems that our culture especially, but also policy, drives us to the doctor's office first. That's where we enter the health system. And there's little consideration for entering the health system by any other means, through other providers that actually maybe be as equally qualified, or in some cases actually better qualified, to manage the condition before them. So that's physician-centric. Hospital-centric, as you'll notice, there have been lots of mergers. The hospital systems are massive entities, and the hospital is really the last place we want people to be. We're supposed to be trying to keep people out of hospitals, but instead we're creating mammoth industries in which the competitive market creates a situation when you pick a health plan, you're picking a hospital system. And that system, so to speak, owns you and controls your care by keeping you within that system. And it's hard for me to believe that any given one health system has the expertise you might need for every condition possible. For example, if I want to have a baby, maybe one health system is really, really much better at that. But if I get cancer, a different health system might be my better choice. Or if I need cardiac care, another system might actually give me the best option. But in our hospital-centric care system, we don't get that choice. We are locked within a system, and the choices are limited, especially if it comes to seeing independent providers and those outside the hospital system.
Okay, I've been asked to ask the whole panel, just to make sure we're all, this is like a lightning round question. Doesn't require really a 2-minute answer from anybody. So can we say how we feel about this? There are so many decisions and opinions about healthcare policy that seem to be influenced by whether access to healthcare is considered a right or a privilege. So what we'd like to know is where you come down. Is it a right or a privilege? Let's just start with Senator Abler.
Actually, it's changed over the years. I've seen it in my time, and we can't do anything in one word. So, and so, if there was a survey taken 20 years ago, it would have been considered something that you buy, like groceries, or you pick a car of your choice. It has evolved over the time. I believe it's if we surveyed the people of this state and around, that people now much more think it's a right. And so I think that's really influencing policy quite a bit. And I think part of the challenge is how to deal with what people believe to be true and how that fits into the political realities and just economic realities. That was short, wasn't it?
Right, and then Ms. Picard, how about you, right or a privilege?
Honestly, I would do away with both of those words. I think when we frame it in terms of a right, it's so polarizing that I think we don't get to any real honest discussion at all about health care. I tend to view it as a necessity. I think if you don't have access to health care, if you don't have good health care, talking about it as a right, it just keeps us from having any honest discussion about it.
I don't care whether we call it a right or whatever, it is a necessity. And it's something Martin Luther King said, the inequality in access to health care is the worst injustice of all. He said that 50 years ago, and it's gotten more unequal since that time. I don't care what we call it, I just want to make sure everybody has it.
I think it's a false choice to ask if it's a right or a privilege. As you heard me say, I think it's an asset.
We don't like the question.
Okay. And I have a question just for Ms. Picard. So as a local independent healthcare provider, what are the challenges you experience providing healthcare services? What would you like to see changed in terms of policy and delivery?
In my practice as a physical therapist in independent practice, I did see barriers. I saw that state policy creates barriers to getting to the right provider. As I said, people come to the physician door first, and oftentimes the referral to other providers is required. And so if the physician doesn't know enough about what another provider might add in terms of value, patient doesn't get there. If the physician has a conflict of interest in terms of where those services should be provided, the patient may not get there. So leaving it up to one person in the gatekeeper model has not been proven to be effective. I would look instead, as I noted in my introductory comments, at population health, which is a public health view, stepping back, seeing how can we create healthy communities that are vital. How can we create conditions in communities that promote health? But then as a provider, I would like to be at the table, just like tonight. Instead of where decision makers are just physicians or hospitals and insurance companies around the table, non-physician providers should be there as well. And the reason why I say that is because as we look at different health conditions, there are lots of conditions that non-physician providers are the best at providing care for. I would also look at episodes of care, the cost of the whole episode, not just the individual provider's cost, say the physical therapy cost versus the surgical cost. I'd add it all up and see how do we bring that total cost down by having the patient enter the system through the right door, getting the right care by the right provider in the right setting.
And Senator Abler, as a chiropractor, would you like to make a comment?
Well, it's not a rebuttal, it's just additioning. So I agree generally with what Ms. Picard said. But I want to throw out a plug to the independent medical doctors. There's like 6 left. If you have a chance to see one of those, please do. The whole world is getting swallowed up by mega, monopolies of health plans, and you already know who they all are. And so somehow that's really not good for what you want. There is some MBA sitting in an office somewhere deciding what their practice patterns are going to be, what their style is going to be. And that is not in your interest. And so in the big plans, you are a capitation, you are a widget in a big machine of their corporate structure, even if they're a nonprofit. So just wanted to add that little plug. Thank you.
That's fine. All right. Let's go next to Mr. Eastwood. We have young people in our audience tonight who are concerned about drug abuse and teen suicide. What role does your organization play in our community with these issues? And what changes in healthcare policy would help your organization do its job?
It's a great question. My organization does a number of things actually in this regard. We operate adolescent chemical dependency treatment programs, both here and also at the East Regional Juvenile Center up in Lino Lakes. We operate, as I mentioned before, the only certified crisis phone line in the state of Minnesota, which handles over 35,000 calls a year. We operate the Text for Life program on behalf of the state of Minnesota. Last year we did 11,000 text conversations, which translates into 400,000 individual text messages from children who were in crisis. Our typical texter is a 14-year-old girl, and that's been pretty consistent. We operate, in addition to that, we also are working actively with all 11 tribal nations in the state of Minnesota to help tribal youth because they have the highest rate of suicide of anyone in the state of Minnesota, and that is a tragedy. We have a sexual assault and victim advocacy program here in the county. We've run that program for over 30 years. And if we are called out any hour of the day or night, any day of the year, we will show up at Lakeview Hospital or Woodwinds Hospital if someone has been a victim of a sexual assault, regardless their age or gender, and we will walk them through that process, what's going to happen, what they will experience, what their involvement with law enforcement will or won't be, and we will stay with them as long as we need to, whether that's days, weeks, or months. So we're very actively engaged. There are any number of programs, but again, and I will probably repeat this time and again, and I hate to beat that drum, but the reality is we've underfunded mental health and chemical health treatment. And until we do that effectively, there are never going to be enough programs. There aren't enough programs in this county right now.
And then Senator Marty, what is the difference, if any, between single payer, Medicaid for all, and universal coverage? That may mean Medicare for all and universal coverage.
Sure. First, I say that what I want to have is what people might call any of those things, but the bottom line is a single payer, what that's conceived of, what it means, something most people don't understand. It's not a very useful term to use, but it's basically one entity would be paying the bills. Medicare for all would be the same sort of thing. The Medicare pays the bills for people who are over 65. I'd like to have a system like that doesn't have the co-pays and the deductibles, and that it's truly one entity paying all the bills. Medicare for all, in effect, that's a way that people understand it, because a lot of people, every one of us, by the time we turn 65, gets on Medicare. And so I use that terminology a lot. But the bottom line is, I'm not interested just in a financing system, but in a whole logical healthcare system, because we don't have one. We have shortages because nobody's in charge of making sure there are enough providers. It's not a hard thing to address. You can address the shortage of providers in certain communities by telling students at the U of M Medical School that if you'll go practice general practice in greater Minnesota, we'll pay you off your debts. We'll buy down your tuition. we will pay you more. There are all kinds of ways you can do it. We just have nobody in charge of the whole healthcare system. And that, to me, is one of the big problems which affects everything from mental health to every other part of it. And it's because we're trying to bring down the cost by just artificially looking at how we're going to bring down the cost that we miss the problems with the current system. And all the reforms, and we've had 10 different task forces or more in Minnesota in the last 30 years. Every one of them is designed to bring down costs. They use these payment reforms, they use all these other gimmicks, and it doesn't work. We're bringing up the costs. We're making the system more and more convoluted every year. We're not giving people better care.
Okay. Let's turn again then to Mr. Eastwood. And so this is a question from the audience for Mr. Eastwood. There are very long wait times to see a psychiatrist in this community. Can you speak to why this is and whether health care policy changes could help this situation?
There are long wait times in this community, and they're getting longer. I'm aware of wait times as long as 9 months in the metro area to have a child see a psychiatrist when they're in need of that service. We are an area that has a shortage of psychiatry. That problem continues to grow and get worse. There was a physician who was practicing here in Stillwater up until a few years ago and passed away and left 350 clients without anyone to see. And that certainly is a burden and a hardship to the entire community. Thankfully, we have good health system here who really picked them up. Stillwater Medical Group did a wonderful job of managing most of those 350 people. I don't know that I have the answers on the policy. I know that we're not training enough psychiatrists. I know that we're not encouraging enough people to go into psychiatry. Some of that's been offset a little bit by nurse practitioners and physician's assistants moving into that. But again, when I look at my own agency, I have 2 nurse practitioners and 1 psychiatrist, and we serve, because of who we are, we serve the most seriously and persistently ill people in our community. We are that safety net, and that takes resources. My agency, with those less than 3 full FTEs, will lose $480,000 this year on psychiatry. To cover the cost of that, we have to raise, and other programs where we lose money, we have to fundraise $800,000 to $1 million a year. That's the only way we keep psychiatry open, and we're one of the few agencies that does that. Some of our competitors and colleagues, they refer their most complex people to us. The solution to that, again, we need to train more psychiatrists, we need to train more nurse practitioners, we need to get them out in the field, and we need to pay them and pay them adequately for that work.
Senator Marty, you would like to make a
Yeah,
comment?
I'd like to comment on that as well. And I think what Matthew just said is right. I mean, we're not paying psychiatrists enough. If you go to your family practice doctor for psychiatric help, they get paid more than a psychiatrist who's got the extra training to do the same work. We're paying less than we should be for it. If you up the pay, if we had a system that logically figured out what we need to pay people to do things, some people might be getting paid less, some would be getting paid more. Psychiatrists, there's a reason there's a shortage. You don't make much money going into psychiatry. You can make 10 times that much going into any other specialty. So that's what we have to do, is we have to have a system where somebody's in charge of making sure there's no shortage of providers, which is what I'd like to make sure that our healthcare system does. The health plan, our Minnesota health plan, would be required to make sure that there are enough providers, and that's not a difficult thing to do if somebody's in charge of it.
So actually, I just would like, I don't have this question in front of me, so bear with me a moment, but we have 2 policymakers here, and could we just be real clear about the shortage issue? So is there data that backs up the assertion that it's typically made that if everybody got health care, we would be subject to shortages of providers? So at least that's what, there's an argument that's made, that we can't all get health care because there just aren't enough doctors. So I'm not talking about psychiatry here specifically. And then there's actually a follow-up question as to this pay issue and the pay issue. But could you, Senator Abler and Senator Marty, both, since I know you work on this at the state legislature, is there data to back that up?
Well, I'm going to just start out saying no, there's no shortage of people in the healthcare industry who could help you be healthy if they were all used properly. If there is a shortage of clinicians, any kind you want, who are going to do all your thinking for you and make every decision for you and make you well while you take no personal responsibility, we're way short. There is a plethora of people out there, many of whom you see as individuals and you pay cash to see because they're not part of your plan. In my career as a chiropractor, I can tell you that I am underutilized, and my colleagues who are highly trained are not utilized like they might be. And there's every study around shows that it's a good idea to have a chiropractor on your crew, and that at the end you'll save some money and be healthier. That would be also true of having a good acupuncturist on your crew, a good physical therapist on your crew, a good naturopath on your crew, a good medical doctor and a good internal medicine, except for me, a good OB kind of person on your crew. And because they could advise you, but at the end, you should take responsibility. In that model, there are plenty of clinicians. The way these networks are set up, the one decider somewhere is deciding you don't get to see anybody but the 3 they pick. There's a big shortage. And just on the whole healthcare thing, we do not have a doctor problem. There could be spot shortages here and there, but we have an administrative problem. And so people that are going to try to run the thing and limit networks and decide you're a capitation dollar. I think I'll just quit talking because I answered the question. Thanks.
That's Senator Marty.
Sure, I will agree with Jim that we ought to be folding into our healthcare system more public health things. We have a growing problem with obesity, with diabetes. And as our population ages, we are going to have a severe shortage of providers. Same thing with psychiatrists. If we do more community mental health, what Canvas is trying to do, we would have less need for psychiatrists perhaps. But right now, we need to fold in public health into the system. On the second part, the actual question, do we have a shortage? I'd say we do in very many communities around the state. We have a shortage of certain professions. Some of the specialists, most specialists we may have too many of, but certainly in psychiatry, maybe dermatology, a few others, there are shortages. And we have to address those shortages in saying that we don't need more primary care physicians in greater Minnesota. Geriatrics is a growing field as the population ages. We have to get more people out there. It's not hard to change that. Again, the University of Minnesota does better than most medical schools, but they too produce more specialists and fewer general practitioners than we need. To me, this is a growing problem. The state, the legislature puts in every few years. We put in $3 million a couple of years ago to bring more doctors, more dentists, more nurses into greater Minnesota. $3 million isn't going to bring a lot of people out there. It's not a lot of salaries, physician salaries. You're not going to bring a lot of people that way. We have to structure the system in a way that works, and I'm very concerned short term that we're going to have a big shortage of certain types of providers in coming years unless we change the system. Part of that's doing more health prevention, public health. Part of it is making sure we train people to do what we need them to do, because we do have a great shortage of general practitioners, certain types of nurses. I don't know about physical therapy, but we have a lot of shortages in a lot of areas, dental being one of the worst.
Okay, and as part of that equation is how much it costs to go to college and then on to graduate school and medical school to then get a job that doesn't pay enough to pay your school debts. Is that part of the healthcare equation or discussions in the legislature?
Yes, it is. I mean, students at med school, U of M, I think they'd say the typical debt is $250,000 just from med school. If you're going through there, even if you want to be a psychiatrist, you're not going to pick that field because you're going to have a debt that's bigger than many people's mortgage. And you try and find something that may pay more. So certainly the high cost of tuition and student loans are a huge hit on the system, but we can fix that again if we have a system where there's a health plan that's responsible for making sure there are enough providers. But tuition is certainly a big part of that.
Okay, Senator Abler.
I just have to tell you, I mean, I'm not sure how many, so one thing, I'd like John, we've had many discussions on this whole thing, but I'm nervous, just to have a little bit of counterpoint here, that the government or a health plan or somebody's going to make sure we have enough providers. And so we're a little short of psychiatrists, so you three are now going to have to go to psychiatry school. Somehow we're going to make you go, and we're going to, you know, I mean, I don't know how that works, but I also am just a bit amused to think that anybody thinks that doctors don't make a good enough living. And I live in a county that's just barely above the median wage of the state, and you know, the problem is when we don't pay doctors enough, their job is just lousy. They don't. It's not what it used to be. They work a lot, and if you're in a career where you're taught that service is first, and that you get to do your best by your patients, people do that forever because they love the work. But now in the system where we constrain their decision-making authority, where their paperwork is massive, where every doctor of any stripe is treated as though they're some kind of a fraud person, and who would want that job? And so they're very frustrated. And now you work for Alina or Health Partners or something. You used to work just on Main Street, and you were the doctor to 1,000 people or something. And so I think part of the issue is it's not as desirable as it was. And I don't know that we want to go back to Marcus Welby, if you remember that, where he was thinking about taking care of us, never mind. But I think we really are pushing them the wrong direction, and it's not as good a job as it was. And I think many people would want to do that if they knew that they were actually free to do the healthcare that they really wanted to do.
I want to follow up on that. For one clarification, first of all, I'm not suggesting some government or somebody should tell people, you go into psychiatry. My point was, if a health plan is responsible for making sure there are enough psychiatrists, they say, look, we're going to raise the rates we pay psychiatrists. We may bring down for some other specialists. You can do it that way, and you give people the incentive to do it. You say, we're going to pay off your debts. If you'll go into a field we've got a shortage of. It's very simple to do. In terms of the other part, I'm going to strongly agree with you on the part about how physicians, now the new quality measures in the last few years, just the reporting, physicians' time reporting is 2.6 hours per week for reporting new quality measures. For their staff time, it's about 15 hours, about 12 hours by staff and 2.5 of their time. That's a lot of time away from patients in order to fill out paperwork. And I think the system has gotten much more interested in paper shuffling, and these mergers make it, again, much less personal. And it was designed to save money, and it's done the opposite. So I think that's one of the things we should be aware of.
Actually, let me get to our other two panelists, and we'll no doubt be circling back to this. Mr. Eastwood, the question from the audience is, what avenues do you see to lower the cost of medical care short of simply not providing it? Where does all the money go?
Well, I don't know that I have that on a grand scale. You know, I can tell you that there's research that goes back 30 or 40 years that identified that as much as 70, or as high as 70% of all primary care visits actually don't have a medical reason for the visit. It's a mental health reason. So from my perspective, it isn't a matter of just pour a bunch of more money in. I think to some degree, I agree where the money is going, where the money is being spent is part of the issue. And we built a system that has probably incentivized the wrong kinds of behaviors. So that if you go to certain neurological centers, everyone who walks through the door gets an MRI or a CT scan. Why do they do that? Well, because an MRI at one point had a $500 profit margin and a CT scan at a $350 profit margin. And people are going to figure out a way to make money. We are good capitalists. One of the things we don't do, however, is we don't differentiate between people with really complex problems and those with very simple problems. In my clinic, we get paid the same amount if we're treating a child who has mild anxiety about going to school or someone who has a chronic, persistent schizophrenia that they're going to be dealing with their whole life. We get the same amount per hour. So I think we shift the money, we start treating people based on the acuity and the chronicity of their illness, and we figure out how to work better with medical and to shift some of the dollars that truly are being wasted on the medical side, and there is waste there for sure. And I would certainly agree, I'm not sure I want to be between these two guys, but for the whole evening, but I would say I do think we are overregulated, and certainly in behavioral health as well. The amount of oversight and regulation and quality management, and every payer has different rules and expectations, including the state of Minnesota, including every county we work in. It is overwhelming. I bet we have someone auditing in our clinic every other week, and that takes 2 or 3 weeks to prep for every one of them. So we agree on something.
We can build on that.
So I actually have a question about audit, but I'm going to come back to that in a minute and go to Ms. Picard. The question is, I am a stroke survivor. We now know that improvement periods for stroke extend past 1 year. Physical therapy can do wonders for stroke patients. Can you explain the part medical insurance plays in extended recovery for stroke patients?
Can you just repeat the last little bit? Can you
explain the part medical insurance plays in extended recovery for stroke patients?
Well, unfortunately, medical insurance sort of defines what kind of benefit you get, and when the benefit runs out, it's over. For example, Medicare has a cap on therapy services. Any beneficiary in any given year only has a certain amount of dollars to spend on therapy. When they reach that cap, they're done. Now, there are some safety nets involved in that today, but that could go away at the end of the year if Congress doesn't take action. So we are driven as providers very much by, will we get paid for these services? We would love to continue to see people as long as the care is what we consider medically necessary. But unfortunately, in the insurance system, it isn't us that's deciding what's medically necessary. It's an insurance provider. It's someone who looks at data and seeks the norm and decides that 1 year's enough and that's it. And the other thing to think about is that the science, the evidence that is coming out through research takes a long time to get into practice. And it probably takes even longer to get to the insurance companies, but it's estimated about 17 years is what it takes to get from bench evidence findings into clinical practice. So we've got to do a lot better job of educating providers, and that's physical therapists included, as to what's actually necessary for people's conditions, what actually works, and we've got to get payers to agree to allow for those kinds of services to be provided without arbitrary caps.
Okay. Thank you very much. I actually have several questions for Senator Abler. And not wanting to leave out anybody, we may end up with some other people answering, but this is a good one, I think, if I know what it means. State government workers declared that their audit methodology on our tax expenditures for medical assistance will remain secret. What will you do to make this methodology both public and conducted according to generally accepted accounting principles?
That is a really good question. On my way here, I was driving and I counted the stoplights, but I also counted up how much money we've spent since I've been in office on public programs. It's about $80 billion in my time. And if you want to, I see you're all raising your hands with the number of audits they've had in that time. That'd be no audits in that time. We're told that the Department of Human Services knows all about what they're doing, and don't worry, the Department of Health is keeping track, and Commerce is establishing rates. No one knows. This black screen is a summary of all the findings they've had, declaring what they know. And that's kind of a joke, but it's kind of tragic. And so I think you as citizens should demand that. And just on the grander scale, we just talked about how, health plans decide what kind of care you're going to get. Whose money, so there's the public side and there's the private side. Whose money is in those health plans? Is it the employer's money? What's money you would have got if the employer paid your insurance? That's money you would have got. And so why does some place down in Egan get to decide what you get? Like, how do they know what you need? And so, but on the, and so that just infuriates me, so that's kind of a tangent. But we need a robust, vigorous audit based upon how business is truly done. And frankly, we passed one this last time, and I'm very dissatisfied with that. And I think Senator Marty and I we haven't talked about this, but I'm putting a letter together to suggest that the legislative auditor actually do a good one this time. And they're poised to do a mediocre one. So we have differences, Senator Marty and I, but we agree wholeheartedly that there should be a thorough audit and find out what have we gotten for $80 billion.
I'll comment that I agree with him on that, the need for an audit. I frankly don't know why our public programs have private insurance companies running them, as Kathleen just mentioned, making decisions on what kind of care we get. I find it offensive that insurance companies or employers or government is telling us how much care you need and what you need. I know the theory is everybody's going to go out and get all the care they can get. If it's easy to get, they're going to get more and more care. We always, I got Friday morning free. I think I'll go get me another colonoscopy. They're so much fun. People are not. We actually like our medical providers, but we don't like to go visit them. We go there when we have to go there. But so I think the idea that health plans are involved in the public programs, I don't know. I think what we need is a system in place where patients and their providers are making medical decisions. If somebody's abusing it, you can crack down on that. But we set up an entire system designed to make sure nobody overgets health care. And we do visit doctors less than people in other countries, but after 40 years of networks and copays and deductibles and prior authorization and all these things making it difficult for people to get care, we're spending twice what anybody else in the world spends on it. Maybe we ought to try a different approach.
Okay. Yes, okay.
All
right.
I like the colonoscopy joke. That was pretty good.
So it's hard, a lot of questions coming in here. Let's go back to Senator Abler. And the question is, what's driving the political divisions regarding health care? And how do we shift that paradigm?
Well, I think a number of people want to talk about this. Probably I was, back to this health care as a right discussion. The political winds, your people's personal views have changed. And what do you call it, a necessity or a right, compared to something you would just choose to have or not. There are some people that just don't want to have insurance. They just don't want it. But so there's a fair amount of, the Democrats are more likely to say it's a right if you haven't been keeping track, and the Republicans are more likely to say no, it's a commodity. But with the evolution, and so there's programs where you can get more free things under like Medicaid expansion and so on if you have low income and so on. But the Republicans decide they don't want to, they're a little dishonest, frankly, at the federal level, and they actually should talk to each other and get along and work out something. All the great successes, yeah, thank you. Hey, finally got some applause, John. All the great successes in Minnesota and nationally have been where both sides said, why don't we work together? The Minnesota Miracle and Minnesota Care and all that. But so my brilliant colleagues in Washington, they don't want to give free stuff. They want to have tax credits, which aren't free either, by the way. That's another way to subsidize people getting money. It's only the way you have the money show up in your budget. And so deep down, everybody realizes this is something we have to contend with. But the error is when the Affordable Care Act was passed, it was all Democrats. They couldn't even get Susan Collins to want to vote for that thing. They could have promised her Newfoundland or something, just, would you we'll annex Newfoundland for you. But then when my colleagues in Washington came their big chance to repeal and replace, they said, we're going to do this all with Republican votes. Did no one learn anything in this discussion? If Mr. Slavitt were here, I was going to say, the five of us here could design a plan that actually you would like, and it would serve the needs. Maybe we still can with this group we have.
Okay, here's a question for Senator Marty. The Minnesota Health Plan bill says that it will lower costs, yet raise coverage by using the same sources of revenue we do now, government, businesses, and individuals. Should we expect higher taxes while our premiums are lowered?
Sure. Our Minnesota Health Plan would stop having you pay premiums to either through your employer or to Health Partners or Blue Cross, whoever the insurance company is. You'd be paying your premiums to Minnesota Health Plan. They'd be based on ability to pay, so everybody can afford them. Some would pay more, some would pay less, based on your income. but those premiums would not go to the government. They would go directly to the Minnesota Health Plan, could only be spent on health care, would not be tied in with the rest of the budget. I don't think you want health care dollars tied in with other important government decisions related to transportation or education or something. Health care ought to be its own system, and premiums would go to that. So the premiums, again, there was a study of a generic universal plan in Minnesota about 10 years ago or so. It suggested a median household income would be saving about $3,000. It would also be funded by payroll tax on business. Bottom line is, the evidence is both because of negotiation. I mean, when we heard earlier about sometimes people get an MRI or CAT scan because it's a very profitable line of business. We shouldn't be doing that. That's why you negotiate prices, to make sure we're not over-providing certain very costly things. But our plan would be saving money, we believe. We're asking for an analysis, but again, worldwide evidence and economic analysis in the States has always shown that a universal plan like this actually saves money, reduces costs, despite the fact it's covering more people. And I know that's counterintuitive, but it actually makes more sense to take care of your needs up front, instead of like with dental care, where I don't know how many thousand people a year in Minnesota go to the emergency room for dental care. That costs about 10 times as much as going to your dentist, and they can't do anything other than give you Novocaine and tell you to see your dentist in the morning. So we've got a dysfunctional system, and we can make it a cost-effective way, but it should be less expensive overall for the entire system.
Okay. Let's switch gears a little bit and go to Mr. Eastwood. This question has to do with the Adverse Childhood Experiences Study. Shows that difficult childhoods create more health problems in later life. What actions do you think could be taken to improve support for families and children?
Yeah, the person who wrote that question is referring to the ACEs study, which is a very famous study that's shown, given the number of traumas you experience in your life, do have a direct impact, direct correlation, if not causal relationship, to your mental health and your physical health in later life. And in fact, they're showing some direct connection between early trauma and actual change in brain chemistry and function. So it's pretty important stuff. You know, how do we impact that? You know, you have to impact it, and this is part of what makes some of this work complex. These can be pretty chronic, pretty entrenched problems. We, within our agency, did a study of a program that we have that's called a family therapy program, which has been around about 30 years, and works with children. All of the children in the program qualify for residential care, inpatient care, but we treat them at home with their families, and we send 2 therapists out to do this. It's very intensive work. We started asking about the parents and their trauma histories, and what we found were that we have multi-generational histories of multiple traumas, whether that would be abuse of one kind or another, it can be accidents, it can be sexual abuse, physical abuse, emotional abuse, and just trauma that people experience throughout their life. One of the things that we have to do is better support those kinds of programs, not just our program, but any program that really tries to understand that multi-generational impact of trauma and begins to try and interrupt that cycle, because that's really the only way, I think, that we're really going to stop some of that from continuing. And for some of these families, it's gone on for generations.
Let me find a question for Senator Marty here. Since health providers could be compensated by a central fund, do we really need insurance companies? What value do they provide?
Good question.
That's a softball for you. Can you handle that one?
I want to say, Dr. Eastwood said something earlier, a couple of things. One about mental health and chemical dependency, and I was going to say one of the other benefits of treating that would reduce our out-of-home placement of juveniles, probably cut that cost by 2/3. Our prison, our field, 2/3 of our prison inmates either have mental health or chemical dependency problems, untreated ones. We'd cut our prison costs, everything else. My argument is we wouldn't need insurance companies. We want a health care system, not a health insurance system. And again, there are some countries in the world that have health insurance systems that actually have a good health care system as well, but they really don't add a lot to the process. Even in those countries, it adds cost without giving a better benefit. And I'm a strong believer that people should get the care they need when they need it, and we should be focusing on making sure they don't need care as often, rather than focusing on how we're going to make sure they don't get the care they need. Because again, all these reforms we've tried have been trying to make it, and a lot of them are insurance-based ones, the HMO movement in the 70s, networks. Why do we need networks? Why can't we, as Ms. Picard said, why can't we just go and get the care we need from a physical therapist instead of saying the insurance company has to approve and they'll only approve this many visits? Why do we have employers telling you what kind of care you get or which doctors you go to? Why do we have government telling it? To me, a logical healthcare system is one, not a health insurance system. You don't need insurance companies to do that, and I'd argue they actually get in the way and they certainly increase the cost, so I'd say no, we don't need them.
And would love to hear from Senator Abler on that.
Well, and actually, we agree on, the insurance companies are easy to not like because what value do they provide? But in terms of, so what do you do then? I want to point out the choices we now have for someone to administer the money that we all chip in case one of us should get sick. Some of us are going to use a lot of that, some are use hardly any, we buy protection. Sounds like the mafia, doesn't it? Anyway, speaking of insurance companies. But so in the models we have, in Minnesota, we have HMOs that control a lot of the functions of healthcare. We have the Veterans Administration, we have Medicare, and we have for-profit insurance companies that sell policies like Aetna and the likes of that. As you look forward to what might happen otherwise, you're kind of stuck to start with about what options you have, and tell me which of those you like. The VA is not really known for, and that's kind of a single payer if you're a veteran. And so even given all the wonders that could happen with caring about that group, it falls short sometimes. Medicare, if you're getting Medicare, some of you are very happy, some of you couldn't be less happy. Some of us are administered by the very health plans that we are so troubled by, and Medicaid in Minnesota is all administered either fee-for-service by the Department of Human Services, which does no management of that, or it's managed by the HMOs on a capitated basis, which, by the way, has not been audited in $80 billion or so. So I just want to point out, as we look for solutions, we have to find a way that actually will work. And how do we take what we have and shift it to something else? But we have to also be realistic that it actually has to work. But maybe it starts in the beginning by recognizing the money that's in all those pots is ours. You paid taxes, you paid premiums, your employer paid something, your mom paid, or whoever. It's our money. And by the way, and the second thing is, if you don't get this from me, you should have not come. It's your business to look after yourself primarily, and then we rely on the experts. Thank you.
So let's turn to Ms. Picard regarding this question involves reimbursement, so obviously from insurance companies. So the whole question, though, is, does your profession as a physical therapist receive the respect it deserves? Does reimbursement reflect respect?
I do think reimbursement is different than respect, but we don't feel respected by the reimbursement we get. That makes any sense. We are a very low-cost provider, but we're a very high-value provider. And so it's not about really the cost, it's about getting access to our services, because the value we bring to the system is that we can save money. But we don't measure that. We just look at how much things cost and attribute value to it based on high cost, high value. And you could have a very low-cost intervention outside of PT, like an immunization, and what does that save downstream is a lot. So, again, just back to physical therapy, we are low-cost providers, but high-value providers. Trouble is, people can't access us at the right time, and they don't get enough of it because there are barriers saying you only get 6 visits, so you can't complete what you need, or the copays are so high for every visit. When you add it up, people stop receiving the care that they need, and then they end up spending more money downstream. So that's my answer.
Okay. I'm actually going to start with Ms. Picard again with a question. So this is a new question. Is it fair and responsible for medical diagnosticians to also own and refer patients to their own treatment facilities?
Is it fair? I don't know the answer to that. Is there a conflict of interest? Yes. Remember the days when a physician couldn't own a pharmacy because there was a conflict of interest, that they ordered a prescription and then made a profit from it if they owned the pharmacy. Well, that went away. But in today's world, the physician can own imaging, can own their own surgical centers, can own their own physical therapy. And with a strike of a pen, just a simple referral can make a profit on services provided by other professionals. And what that does is control the marketplace. It allows one professional group to control the marketplace of another. And I don't know whether that's fair. I just don't think it's good public policy. It doesn't protect the patient.
Can I comment on that? I want to say that, yeah, I think the conflict of interest is a huge expense in our system. I think it's inappropriate. I think that's why we need a healthcare system to say you can't do that. For things that a doctor would do in their own office several years ago, for maybe a couple $100, they now do it in a separate facility, and the facility can charge $800 just for the facility fee. New ways of doing it. It's very creative capitalism, perhaps, but the idea that people can refer patients to other, a doctor should never get extra pay for referring somebody to a certain service or referring them to their own clinic. And to me, that's one of the things Minnesota Health Plan would be required to do, is to start moving away from that and ban those conflicts of interest, because we shouldn't be allowing that kind of system to be governing our healthcare system. It's extremely expensive.
Senator Abler,
Well,
please.
thanks. You know, there used to be some laws called Stark laws, which prohibited some of that behaviors. And over time, if you have enough money and enough time and know people in Washington and St. Paul, you can kind of get your way. And so one of the things the league is favoring is that people would be involved and actually discuss things, watch issues that are coming up, actually be the voice. Like, we think that's a bad idea, you would say as an individual when you hear some group wishing to pad their particular nest about their practice style or their business opportunities. And you should get mad about it and say, why are you referring me to your place for an MRI, doctor? That'd be an interesting discussion. But also that means you're asking the questions. And one thing that I've worked for a long time, and I'm sorry I failed so badly, is to have more transparency in pricing. If you go to your doctor of any kind, any therapist or chiro or whatever, and you say, what is this going to cost me? If I write a check today and what would that cost? We don't know. We don't know. I don't know what you're going to be getting. Well, I'll get reimbursed for your visit. I have a cash price that is actually about the price of your copay, and so which has soared up and up. But so there is no substitute for an informed electorate, for an informed patient. Even the name patient is kind of demeaning. And, you know, you're kind of a client or whatever. It implies you're sick. Maybe you want to be well. So you're here to learn about healthcare and how we're going to solve it. Part of it is look in the mirror and be friendly, but a little assertive, and say, why do I even need that test? So if I do this test, are you going to change what you would have done? Do you have an inkling about what you might do differently if I actually had this expensive, dangerous evaluation? And, you know, that's my suggestion to you. And then some of these matters become moot. There's a lot of money spent that is pointless. And the result only confirms what everybody already thought was true.
Okay, so we've been going at this quite a while, and I'm thinking I haven't heard one good thing about the healthcare system in the United States. So I'm wondering if a valid question of each of our panelists would be, is there even so much as one good thing about healthcare in the United States? And then we'll return to a bunch of these questions. Why don't we start, though, with, since Senator Abler just got, let's start at the far end with Ms. Picard. And is there anything redeemable with our system?
Absolutely. I really believe we have some of the very most highly trained individuals, competent individuals. Unfortunately, we're the most restricted in many ways from practicing at the top of our license the way we're trained. But whether we're physicians or physical therapists or chiropractors or anyone else, we've got great providers. But like Senator Marty said, we don't have a system that coordinates that care, that develops models of care that make sense for where the patient should enter the system and who they should see in what setting. So it's the organization of all of those wonderful providers that's really not adequate.
I'll agree with everything Ms. Picard said, and will point out that at the beginning I did say some very nice things about our health care. I think I said we have some of the best providers in the world, and best research, best technology, best training. Great providers, great system, but the worst system for accessing it. And so my only beef about it is we don't have a functional system of making sure it comes together well, which has huge impacts on health outcomes, it has huge impacts on cost, and that's why we need a healthcare system that's funded and operated in a logical sense. I don't think there'd be huge disagreements among anybody here about the direction we want to go. You don't want to have people going to the wrong provider because somebody makes money referring them to their own clinic. There's radiation oncology. The state has been trying to limit the number of facilities because they're so expensive. Well, there are two of them across the street from each other at St. John's Hospital in Maplewood. One's the hospital, and one's some doctors decided they could make money operating their own clinic. There's no logic. It's hugely expensive for the system. We need a system that makes sense. That's all we want, is a common sense system. But back to the question, yes, we've got excellent things, so much good stuff going on. It's just we mess it up in the way we administer it and make it twice as expensive as it should be.
Mr. Eastwood?
Yeah, I go back to a comment I made earlier about that there are very good people doing this work, both in Washington County and across the metro, and I formerly had a job that took me across the state working with mental health providers, and they are exceptionally well trained. They're constantly trying to learn new evidence-based practices. Unfortunately, true story, I had an AFSCME union negotiator tell me that any one of my master's level licensed mental health therapists could make more money as a janitor at any one of the hospitals in the metro today. Not a good place to be. The people who work with me, the people who are me in the community, are mission driven. They do this because they are committed to helping people. They're always trying to improve their skills. They're always trying to move forward. I think that's really the core. We have wonderful people doing this work every day.
Well, nice thing is our hospital has a lot of parking spots. The lobby is really nice. There's some cool plants out there. Anyway, and the view out the windows is amazing. We have, actually, we just needed to laugh a minute. And I don't think you hear us all saying everything is horrible. I think you're here, we're all here because I think there's something can be made better. But you take there's a bell curve of clinicians, and 68% of those are within one standard deviation, if you remember your statistics. There's maybe the top one, above one standard deviation, there's 16%. 84%, in my opinion, are some of the most amazing clinicians anywhere. They wake up every morning, how can I serve you? How can I make your life better? How can we, and it's the nurses, the nurse practitioners, the PAs, all the other providers that are around, they are truly interested in making it better, and that's the wealth of our system. We have amazing supply of alternative providers, naturopathy and acupuncture and others, and chances we have a very friendly law in Minnesota. You can choose who you want as long as they sign the informed consent thing. You can see anybody you want, and they can do really amazing things for you. We discuss how we'll pay for it. Some of those doctors who are so amazing get hamstrung. And we have a very bright, informed citizenry who, when you give them a chance to understand their choices, they actually decide pretty well. And we can build on that. And that to me that's my presupposition in everything that I work off of, is those caring clinicians, the choices we have, and the people who know how to make wise choices. Upon that premise, we can have an amazing healthcare outcome for each of you.
I've got a request to ask this question of all, I think. Block granting is proposed as an alternative to the ACA, the Affordable Care Act. How would block grants work in Minnesota? And are they a good idea for our state? Who would like to start with this? Senator Marty?
Sure. I think block grants were intended, they're being proposed in order to cut spending for healthcare, so they can give bigger tax cuts. Basically, the ACHA was largely taking dollars away from healthcare, not to improve healthcare for anybody, but to take away healthcare and to give it back in tax cuts. That's roughly what the system did. That's the largest function of what it did. And basically, it would be tying a state like Minnesota. I mean, they're now saying that in exchange for approving the system for our individual market, they want to take away several $100 million from the Minnesota CARE program. In effect, if block grants were saying, you states can figure out how to do this, but we're going to make sure you get enough money to do it, no, their plan is to cut down the amount they're spending on healthcare. It's not a reform for healthcare. It's simply a way to spend less money so they can, and not so they can use it on other healthcare in a logical way for people who don't have it. It's basically so they can give tax cuts. And I want to bring down the cost of our healthcare system, but our biggest problem is not that too many people are getting healthcare. The problem we have is too many people aren't getting the care they need, and it's not just the uninsured, it's the 90% who are insured who can't afford to go to the dentist, or they can't afford the co-pays or deductibles. And so the idea that somehow we're going to cut back on the care available, the whole thing on Medicaid, cutting back on Medicaid, taking the poorest and sickest people and saying, we're not going to cover as many of you, but those folks don't cooperate, they don't stop getting sick. And then they don't stop getting sick, and we end up paying for it in the long run. So it makes no sense. The block grants are a terrible idea just because it's nothing to do with healthcare reform. It's simply to do with taking money away from people who need healthcare and giving it to people who don't really need tax cuts.
Did you want to comment on that? Did you want to comment on that? Ms. Picard, would you like to comment on that?
My understanding of the block grants is that they would be available for individuals who qualify for medical assistance. So that's for the very poor. And that might work for them if there's enough money. It's not a needs-based block grant. It's just here's a given finite amount, figure out how to spend it. But at any rate, it's for the very poor. Well, what about the kind of poor and the sort of poor and the up this chain or up the continuum of poor to not very poor? So it doesn't provide a safety net for those people who aren't low income enough but still can't afford to buy their own health insurance.
Yeah, I don't see anything good about a block grant process unless they suddenly decide that they're going to fund it at appropriate levels, and I don't see that happening. I would certainly agree with Senator Marty about this, and I think it would be actually devastating to where we are currently in Minnesota in healthcare.
Well, let me, just to understand, each of you pays a premium. I presume most of you have some kind of insurance in here, and someone has decided they're going to pay a premium. You're participating in a block grant, just want to caution you. And so you're capitated in your plan, and if enough people pay in that amount, then it's going to be fine somehow. And so I understand Senator Marty's concern, and he's very eloquent describing that. But block grants in and of themselves are neither good nor bad. They're just a method to fund. And I want to caution you, I believe that if we were to ask all of you, should we continue funding our programs the way we do, you go like, no, they need more money. And I'm not going to debate that with you. Let me just point out how we fund our federal programs right now. Generally, if we spend $1, they give us $1. I've had 6 teenage sons, and so let's say we're going to go buy a car, and I say, well, you put up $3,000, I'll put up $3,000, and so we agree that that's the price. And he comes back and says, good news, Dad, I found a car for $20,000, I'll pay $10,000, and now you pay $10,000. And that's the federal government, how it funds. There is no incentive to make sure the money goes anywhere good. And the strings that come with those federal dollars, I joke, if I was ever the Commissioner of Human Services, I would fire the federal compliance officer, because they always say, we can't do anything. We can't try that. And so I said, well, wait till they send us a letter and tell us we can't do something. And so if you want the money to go further, then you find a way to make sure that you have the local flexibility. And so if you're going to do block grants, they shouldn't tie the healthcare and Medicaid together. They should be distinctly separate. But giving Minnesota flexibility to spend the monies that we have, which are like $15 billion a biennium from federal money, and a similar money from us in the human service programs, I think that has a great potential.
Okay, so I've got a question that's for Senator Abler, but technically it's a yes or no question. We'll see how he does. Can Minnesota pass laws for Minnesotans to buy drugs in Canada?
Yeah.
There you go.
Why not? For heaven's sake. So you can go over there and, well, John Marty has a riff on this. Do you want to do the John Marty foreign bought drug riff? I want to hear it. It's amazing.
We're spending 40% more than Canadians for drugs, and that's because we don't have a system for negotiating drug prices. We ought to do that, but in the meantime, I agree with Jim, we ought to be allowing people to buy drugs in Canada.
Okay, let's move to this one then too. Senator Abler, several states have introduced or passed bills that attempted to control the cost of prescription drugs. Would you consider such a bill for Minnesota?
Yeah, I don't know a lot of Latin, but I think PBM stands for devil in one of the languages. And I cannot explain, well, sorry, we have some big PBMs that house themselves in our state. There is, if you ever go to watch that 3-card game and you're in New York and they're like, find the 6 of spades, and there is a sleight of hand in that program between the pharmaceutical companies and the PBMs and the payers, and they give rebates that are massive to you, but you pay retail if you're on insurance and you have an auto case and you're going to pay 100%, and it is crazy. And no one knows where the money goes. And if you're going to audit anybody, maybe it should be them, because I think that the abuse of the system in that part is just horrendous.
Okay. I've got a question for Mr. Eastwood. And this is, for example, relating to, for example, schizophrenia versus a person with schizophrenia versus a child with anxiety. If you charged differing amounts for patients' problems versus flat rates, how would you ensure all patients receive quality care?
Could you repeat that?
If you charge differing amounts for patients' problems, different problems, versus a flat rate for just whatever the problem is, whatever it is, how would you ensure that all patients receive quality care?
Well, that's an interesting question. I don't know that I've thought of it in that way. Here's what I'd say about the acuity aspect. The state has defined very clear ideas about what severe emotional disturbance is for a child, or emotional disturbance, or a child with no problems, or a serious mental illness versus serious and persistent mental illness. And you have to meet certain criteria to be in that group. And it's not a group you want to be in, trust me, but if you're in that group, it's based on your diagnosis and the chronicity and the expectation that you're going to, certainly with serious and persistent mental illness, this is going to recur during your lifetime. I think setting payment rates attached to that addresses the fact that it requires more service, it requires more time, it requires a more highly trained staff to work with someone with a serious mental illness or a serious and persistent chemical health problem than it does to work with a 6-year-old who's having a little anxiety about going to school. I mean, that just makes sense. That is, by the way, also how the medical side of the world works, because they have complexity in their coding. If you look at E&M, something's called E&M coding. That's how those are structured. Most of mental health is not structured that way. It's a simple change, and actually wouldn't be very hard. I've suggested it to the state 3 times, but they don't listen to me. But it'd really be a simple thing to add just a little modifier to codes. And then on their audits, because they're auditing us all the time, they could look at the record and look at the bill, and they'd see if this person really does have a serious and persistent mental illness.
So let's move to perhaps kind of a related thing, to Ms. Picard. What can we learn from other countries regarding insurance coverage for physical therapy and mental health services?
I think the most important lesson we can learn from other countries is to cover those services. and to pay an adequate rate for those services, rather than cutting it out completely and just depending on physician and hospital services. One of the motivators for me to be here tonight was to try to express the value that non-physician providers bring to the system. It isn't just physicians that patients need, and all providers need to be at the table. The trouble is, we're not at the table, and we know that if you're not at the table, you're on the table. So you can easily be cut, your rates can be cut, nobody dies because they don't get physical therapy. So it's not very sexy if you just say, oh, we're going to limit you to 20 visits in your lifetime. It's, no one pays attention to that because it isn't critical care. But unless it's you might think it's critical care. What happens to you when you have the stroke, when you're afflicted with another condition for which physical therapy can help, it's critical to you.
Okay. We've covered a lot of this ground, but I'll ask this question anyway of Senator Marty, this is from our audience. Please specify why the United States spends so much more on health care than other countries. People in other countries make bad personal health decisions just like us. What's the difference?
The difference is we have a dysfunctional system. General Mills executive healthcare related by General Mills has it, well, every business has to have healthcare executives because it's a convoluted system. He said about 10 years ago, if you tried to design a healthcare system that didn't work, you couldn't have done a better job than we've done. And that's what we've got. We've got a system that makes no sense. We spend far more, and the prices, just the pricing. There was a study last year out of Yale that suggested that a lot of the reforms have been done to have mergers so we can have more comprehensive care, and all the mega mergers that were caused by some of those reforms have not brought down costs. And they've made it actually worse because the bigger the hospital system or whatever, the more negotiating clout they have and the higher they raise their prices. And this Yale study showed that on certain types of common medical procedures, I don't know whether it was a knee surgery or what, the range was from $3,000 to $55,000. That's 10, 15 to 1 price disparity. Try and buy a car and you're going to buy a Toyota Prius and you're going to pay 5 times as much as another person buys for the same new car? It makes no sense. So we've got a convoluted system that wastes money, and the more intent we get on, we're going to focus making sure somebody's not ripping them off, making sure that Canvas doesn't overtreat somebody. That's the whole bizarre thing. We're being penny wise and pound foolish by trying to make sure nobody's giving somebody some care they don't want. I frankly think people should get the care they need, and we should try and make sure people don't need as much care. But instead, we make it so it's hard to get it, so people better get it. I can't explain all the ways in a very short period of time, but there are dozens of ways that we spend more than other countries, and we do not get better outcomes because we don't have healthier people as a result, because we're not treating them in the right way.
Okay. Ms. Picard would like to make a comment, and
Yeah,
then
just like to
Senator Everly.
piggyback on a comment you made about trying to reduce the cost or the variability in cost with certain procedures. Medicare has a bundled payment policy for total knee replacements, where they're trying to get the cost of total knee replacements to be less, and hip replacements as well. So while everybody's driving at getting the cost of these procedures to be less, no one's talking about doing fewer of them. And that's where the non-physician providers come in. Physical therapists, all of the research on early onset osteoarthritis is mobilization of that joint and physical therapy. Get it moving, get it strong. You can push that knee replacement out much farther than what we're providing now. We're seeing younger and younger people having knee and hip replacements. When I'm not saying not all of them don't need to be done, but many do not. But we're not focusing on doing fewer of them by doing preventive and conservative management first.
Senator Everly.
And I'll just echo a bit of that same thing. Oh, they were clapping. There you go. Anyway, just to echo a bit of that, we pay for the wrong things. If you were, and just to say it a different way, then I pretty much agree with it John and Kathleen said it, but many of you actually own a car in Minnesota, and occasionally it doesn't want to start. And so if your car doesn't start, I don't know if any of you actually call the tow truck right away and tow it into the place. Any of you do that? No, you wouldn't do that. You think, I need a new engine. My problem is the engine. I'm going to put a new engine in that thing and maybe it'll start. No. Most of you don't even go out and buy a new battery yet. You go take 2 jumper cables and you take your neighbor and you see if it's going to go. In healthcare, we do nothing of the kind. The way the system is set up, and I agree with John, is that it's a mess, but it's set up and so it pays really well for the tow truck. The tow truck is actually free in your healthcare plan. The engines are really cheap and they don't pay for jumper cables, generally. And it's crazy. And so you as consumers should say, I wish I could have jumper cables. And the conservative care world is waiting to meet you. And when you go there, they're going to suggest how much water do you drink a day? What kind of water? Is it like that nasty stuff with the chlorine? Or how about like some good water without poison in it? How about vegetables? Do you eat many vegetables? What are they? Well, they actually are in the store. And McDonald's is not the finer place to enjoy your life at. In fact, if you want to not live well, you will live there a lot. And so there are a lot of things you can do that make you require far less. And that's what you want to buy. And by the way, it's way less expensive. And never mind the money, you're going to actually have a better life. Thanks.
So actually, given the time, I have a closing question for everybody that I ought to get to. And we decided to do this in reverse order of the opening remarks, so that puts Ms. Picard again at the beginning. So are you ready for this? What can we as citizens, what can we do to ensure that all Minnesotans have access to quality health care they can afford? How can we, the citizens, influence the debate in Washington and at the state legislature?
I think the most fundamental thing anyone can do, and it's an act of advocacy on your own behalf and everyone around us, is vote. You need to be aware of what's going on, read about it, listen to you, just like you are here tonight, finding out more about it. But in the end, it's around policy that's made in state legislatures and at the Capitol in Washington, D.C. So I would say the one thing, if it's one thing at all, you must vote.
Senator Marty?
I'd say that, yes, voting as public policy, we have to change our public policies because the system is sick. Also, taking care of your own health and advocating for yourself is also important. Earlier at the beginning, I talked about when we were asked whether we think of healthcare as a right or not. I said, I don't care whether we call it a right or not, I just want to make sure everybody gets it. But when we talk about is it a right, some people in Stillwater here actually have a constitutional right to healthcare. Who are they? Prison inmates. Because the state has control, the U.S. Supreme Court says they have a constitutional right to comprehensive health care. And that's appropriate. I kind of think everybody else deserves the same right, the same health care, and it's not that hard to do. And that's why we ought to do it. And I'd say the way we get around some of the partisanship around health care policy is instead of saying, well, we want a market approach or a single payer system or something else, is just spell out the principles, what we want a healthcare system to do. I put together 10 of them about 15 years ago, put them all into the Minnesota Health Plan because I think every single one of them is important. Healthcare system should cover everyone with 0 exceptions. It should cover all your medical needs, including dental and vision care and long-term care and chemical dependency treatment. It should cover everything. And decisions should be made by patients. They shouldn't have networks. They should be able to choose which providers they trust, and decisions should be made between them. And we should focus on prevention. An ounce of prevention is worth a pound of cure. I've spelled out 10 principles. I think if you can meet them, I don't care if it's a single payer or what kind of system it is. If you can come up with a plan that meets those 10 principles, I'll sign on for it. Because that's all we need is a healthcare system that covers everyone. And frankly, the rest of the world figured that out. And I argue, well, my plan might not pass this year. I kind of know it's not going to. I think Jim knows that too. But I actually think the Trump election speeds up the chance it's going to happen in the next 4 or 5 years. It makes it much more likely. And finally, I'll say one more thing about it, is that Winston Churchill once allegedly said that Americans will always do the right thing after they've exhausted every other possibility. And I don't know if he really said that, I don't think he did, but it's a good point, and that is, we're at that stage now. You look at the reforms being proposed in Washington, they're not going to fix it. They simply aren't. What we did this year, we temporarily brought down costs. I'll stop. We temporarily brought down costs, but we didn't do anything to fix it, and I think it's time we do that.
So, Mr. Eastwood, what can we as citizens do?
Well, I'll explain that, I think, or answer that by telling a brief story. And in that I think we're in a unique place in Minnesota. I don't know about the federal level, that's a whole nother nightmare. But in Minnesota, this past year, my agency pushed forward a piece of legislation. And I spent a lot of time down at the Senate, I spent a lot of time down at the House, I spent time at the governor's office talking to people. And I will tell you, we had equal support for our bill from Republicans and Democrats. And these two gentlemen, both of them, signed on to the bill. I was stunned, honestly. I was stunned. I think in Minnesota, I think Republicans and Democrats, by and large, get it about health care. They may not always agree on the solution, but I do think they care about it. I think that is a unique position to be in. I was very encouraged when I spoke to both of them, whether it was in a committee or it was in their office. They made access available to us. We ultimately didn't get funded for that, but it was a very eye-opening experience for me about what these folks care about and that they do care and that they really do want a better system. So I would say take advantage of that. If there's something that you think is an important bill, I would say call them, write them a letter, email them. They may not read that email, but somebody on their staff's going to read that email and will pass that information along, and that does make a difference. I know that makes a difference because we were within 12 hours of closing down Crisis Connection this summer. And because people reached out and made their feelings known about that, the state stepped in to at least provide some bridge funding to get us to the next legislative session. And that didn't happen without people like you reaching out and saying, hey, this is important and I care about this. And these people do care. And I feel very confident about that. So.
Well, this has been just a really good discussion. I don't know if we've actually solved it tonight, but it's good you're here and you're engaged. And one of the best things about being first in the panel like I was is like it was all new stuff that I got to say when I was the first speaker. Now at the end they all said all the good things that I could ever make up, including the right answer, which is to vote, since the legal women voters thing. So way to be, Kathleen, you got that right off at the top, so now I can't say that anymore. What you're doing actually is part of the right thing. I've been elected 18 years, which I can't believe. I've been in practice 38 years. And believe it or not, that 38 years of experience really helps me understand every profession. And for all the parochialness in my time, and I've been able to work with virtually every provider group and see what they're about and help them understand what they need to do. Many policy, and that wasn't, now it's not like I'm bragging about it, but if you look at who's making some of the decisions currently in the legislature, and in Washington in particular, you're having people who have no idea what they're doing in a back room making a decision. And how do you influence Washington? I have no idea. It's so far away. If you had somebody go there who actually knew something about healthcare and was interested in a compassionate way about you all, that would be a start. And so you are the start of making a difference. You are engaged by coming here, missing the Vikings game, and watching this discussion amongst people who agree on many things and not everything. And so if you push me and my colleagues to actually make decisions that are not partisan or parochial, and it shouldn't be those decisions, it shouldn't be that way, you will see a better product. Each of you has at least one senator and one representative. Some have more because you have businesses. Talk to them. They're home now, hanging around. And so be a part of it, and you will see your fingerprints on that. But my advice to you is, remember, prevent, be healthy, and take care of yourselves. And by that way, the money will go further, and we can actually do better by other people. So God bless you all. Thank you.
So this actually does bring us to the closing remarks, and I may have messed that up a little in my,
Okay.
but this was the closing question. If you have, I know the senators will have something to close on, but to your actual, if you'd like to just, one more thing, we'll start again with Ms. Picard, and just come down the table and wrap this all up, and then we need to talk to you before you run out of the room for one moment. But if you'd go ahead.
Sure. I just want to circle back to the first question, what can you do? Since I was first to answer, I didn't have much time to think about it. But as I listened to the others, I thought about another thing. You can go to Consumer Reports, and there's a whole huge campaign called Choosing Wisely. And all of the medical societies and professional organizations work with Consumer Reports to publish help for consumers to know that when you go to your provider, questions to ask, what to push back on. Don't ask your provider, why are you suggesting that? The research doesn't say that. It's all there, very concise, written in ways for you to use as a consumer yourself. So I just wanted to add to that. Our discussion around where is all the money going is one that I just want to make another comment about. The Institute for Medicine estimates about 30% of what is spent on healthcare spending is unnecessary. Unnecessary care. So there's a lot of money involved there. And that might be care that generates dollars or profit. That might be defensive medicine. And I'm not sure if I buy the argument that tort reform will really fix that. Especially because there's another defensive medicine concept in that providers are being judged based on their patient satisfaction. So physicians will say, if I don't prescribe the drug my patient comes to ask about, then they're not going to be satisfied, and I won't get a high rating, and then I'll be put in a bad tier, and I won't get good reimbursement. So all providers are driven to make their customers happy or their patients happy, but to the point where they're providing unnecessary services. I would also say that some of the money goes to just not the right care. Instead of providing all kinds of invasive procedures and pharmaceuticals and such, conservative management of a lot of conditions will save that money as well.
There are a lot of reforms we've tried in recent years. Many of them were misguided. I think Kathleen just mentioned one about rating providers. I mean, one of the ways they're compensated is if they're satisfying their patients. But that doesn't do much good when you have a doctor who's got somebody coming to them asking for more opioids, and the doctor may not want to give it all to them, but, you know, I want better ratings. I mean, a lot of the things we've been trying to do are not bringing down costs. They're bringing up costs. And in my mind, what we ought to do is start out with what our principles are, what we want to do, and that's what I proposed in Minnesota Health Plan, Senate File 2019. I think it makes good sense. I think it would save money. I think we'd be the first state in the country to make it happen. I think other states would copy very quickly. We can't afford not to. And I know it's not going to pass this year, but again, they're going to have to come to it eventually, because every time we do one more misstep. The Affordable Care Act covered a lot of more people. It cut the uninsured rate by half, but didn't fundamentally fix any of the problems with the system. And I really object to the idea that people say the biggest objection they have to something like this is, well, it might make sense, but it doesn't have a chance. You know, nothing worth doing is going to be easy. Women's suffrage, they didn't have a chance either. Legal women voters came out of that. Men made all the decisions. Who elected the men? Men did.
That was very well done.
How did they change it? They said it was wrong, we got to fix it. I don't think it's unreasonable to say we can fix our healthcare system when other countries, it's not rocket science. Every other industrialized country fixes it. They make sure they do it. It doesn't mean they're all perfectly healthy. It doesn't mean we're all going to be perfectly healthy. It's still going to be expensive, just not as expensive as we have. We just have to have the political will to do it. So I urge you to join us in working on that effort. So thank you very much.
I know I shouldn't have been stuck between these two guys. You know, I don't have a grand policy statement. I think I've been pretty clear about what I think about my little piece of healthcare and where I come from. You know, behavioral health makes up, or mental health makes up about 7% of the total spend in healthcare, which is, to me, appalling. I think I've made that clear by now. The fact that 30% of the people in this country, 30% of the people in this room in their lifetime will experience a mental illness, and yet it's only 7% of the total spend, just doesn't make any sense to me. But I think I've sort of beaten that into the ground for this evening. What I really want to say to you is I really appreciate you being here. I don't think it's the Vikings game, because they're like 2-15 when playing in Chicago, so there was nothing good going to come out of watching that game anyway. And since I've been a fan since I was 3, and nothing ever good really does come from that, we should just let it go and move on. But I appreciate your being here. I appreciate you giving me some time to talk to you about mental health and chemical health, and then what I think are the needs in this county and in this state and in this country, and I appreciate that very much. Thank you.
Well, I feel really special. I get to have 2 closing statements, so that's pretty sweet. I didn't think of the women's suffrage thing. That was a pretty good thing there, John. But anyway, I want to thank the League and the St. Croix Valley Women's Alliance for what they did tonight. I think if there were more of these kind of forums, I think people would make a difference. So actually, I had time to write down my 14-word closing statement for you all. So you have power. You matter. You can make a difference. So go do it. Thank you.
Go ahead. So, first of all, I want to thank our panelists, and I think we should all clap for them together. It was an incredible Minnesota conversation. We made it a Minnesota conversation. And I want to thank you for your participation in this first community forum on healthcare. Many healthcare organizations and advocates in the St. Croix Valley were invited to attend, and we welcome a continued relationship with you in the future. My name is Kava Zabawa, and I'm a registered nurse and a member of this amazing forum organizing team of League of Women Voters and St. Croix Valley Women's Alliance. We feel that healthcare reform is the issue that we all share, and it's going to take all of us to create a healthcare system. We need community conversations to help us determine how we go forward to provide healthcare for all our citizens, healthcare we will all be able to afford. So I get to do the call to action, but the panelists did quite a bit of it, and we need to engage, we need to get involved, and take this healthcare conversation forward. So I'm just going to add just a few more things, because I think we can work individually by talking with our elected officials, because our opinions really do matter to them. But we can always work collectively as well. So we can contribute or join a statewide or national organization or your union working for healthcare reform. You can take electronic action with others, join a community Facebook group, and of course, get out to vote. And please contact us, the League of Women Voters, the St. Croix Valley Women's Alliance. Join us with our work on behalf of our community. Our contact information is in the back of your program, and we have more information at our sponsor desk, as well as John Marty's Healing Healthcare. All proceeds of that book go directly back to the printing. If you would like to see more educational forums like this one about the issues that directly impact our community, please help us with a donation before you leave, and also your written evaluation and comments. We want your ideas for forums for future, and there will be a donation box near the exit. In the words of Martin Luther King, I will say the whole quote. Senator Marty. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We thank you all for attending, and good night.
Cool parting gifts.
I asked you already about barbecue chicken or... So if there's a certain